Hi friends, today we will be discussing about the ENT paper 1, that is which is just there for 100 marks. So if you see the distribution of marks in ENT, so according to RGHS they say ear comprises for 42 marks, nose for 32 marks, throat is further classified into 4 parts, of which pharynx has 10 marks, larynx has 8 marks, airway has 10 marks, and esophagus has 6 marks. So totally it comprises up to 34 marks. So okay, based on this we'll see how to approach the paper per se. Okay, so if you see here, one long essay, so one long essay you can expect from here. Okay, and the second long essay, either you can get 2 CBQ or 1 CBQ is for short. Okay, so one long essay is from here, either you'll get CSOM or cholesteatoma, or if the paper is a kind of a bouncer, you might also get a question something related to Meniere's disease also. So that's a question mark, but something related to this is a short question. And then when it comes to nose, what is the short question is, either you get a epistaxis related CBQ or a polyps related CBQ. Mostly you will get a ethmoidal polyp ka question, or even you might get AC polyp, but this is what is the most important thing. But with respect to throat, what is the important question is tracheostomy. Then one coming to short essay, so where you can get almost like 40 marks, one question related to your one CBQ will be there. That depends on what was the second question of your 10 marker. Either you might get it from throat or you might get it from nose. So you should understand which is the thing which you are getting. For example, if it's from nose, something related to rhinosporosis, or a CBQ of something of that sort will be asked, and one question regarding your deep neck space infection, that is parapharyngeal space infection like quinsy, all those things is important, and or something related to esophagus or something related to your throat part, that is acute epiglottitis or something like that. And one question related to larynx or face fracture is kind of short. And if tracheostomy is not asked here, one question related to tracheostomy will be asked in 5 marker. Somewhere related to tracheostomy they have to ask you a question either in 10 marker or 5 marker. Okay, and this can be a CBQ itself, this or this. And something related to F is short for 5 marker or 3 marker. Okay, coming to here, so one question related to again, or depending on what was asked there, these are the questions which you can expect. And something related to outer ear is one question, or something related to infection is also important. And for sure, one question related to implants or ototoxicity or hearing aids is also important. Then you have 3 10-marker question. So one question related to facial nerve, for example topodiagnostic test, something like that is important. One question related to anatomy, for example nerve supply or blood supply of ear as such, or they might ask you to draw lateral wall of nose. Okay, or blood supply of adenoid, or blood supply of adenoid or tonsils. These are like short questions. And 2 questions something related to name test, for example glycerol test, though these are RS2 kind of pattern, something related to for example English test, Weber's test, something related to that will be asked. 2 questions from 3 marker will be something related to, they might ask you causes of tinnitus, causes of referred otalgia, what are the 3 pre-malignant lesions, what is Ramsay syndrome, what is Rinke's edema, something related to that you will get for your 3 marker. And one question related to rhinosporidosis is or rhinophyma, either in 5 marker or 3 marker is like short. And 2 questions something related to throat, for example Vincent angina, plumber Vincent, something related to throat is short. And one operation related question will be asked for short, for example tympanoplasty, myringoplasty, or CRM. So something related to that will be asked. So this is what in total I wanted to say about the paper prediction, which is for 100 marks, out of which we can aram say predict 60 to 70 marks. So remaining all based on your previous knowledge or the knowledge which you have in these questions, you can apply it and you can derive the answers for the same. So now we'll see what university has to say. So this is based on your Singhi and Dingraka Dingraka notes. So, regarding to anatomy and physiology, these are the chapters which are present, and diseases of external ear, this thing, and this one. So basically, one which is highlighted in box is something which you have to finish first, then you can go to other parts. So here you can use this for references to study which chapter based on the particular topic. So notes, they are divided into majorly into 4 topics. These are the major 4 topics, and I have written what are the important things also. Then related to throat, they have divided into 4 marks, something related to stridor and tracheostomy, something related to larynx, something related to nasopharynx and oropharynx, and something related to dysphagia. So these are some important questions which they expect you to know. So based on, and also operative procedures. Okay, though operative surgeries, they can ask you, basically they might ask you about indications, contraindications, complications. So any operative surgeries, when you are studying, make sure your narration or you study accordingly. Okay, now coming to ear proper. So if you see, ear only has one of the biggest marks are weightage, and that too, firstly we will start with infection of middle ear. So under Singhi or your Dingra, these are the 4 questions which you need to cover. These are the 4 chapters which you need to cover under the infection of middle ear. So these are the 10 markers, 5 markers, and 3 marker. Okay, though ASM was asked in RS3, we cannot take risk, right? So this is one of the important 10 marker which was asked. Okay, so based on this, let us first we'll build the concept. So whenever they say secretory otitis media, remember it's a problem of eustachian tube dysfunction. That is, you will have negative pressure. Okay, so you will have sterile fluid, and this are same. That is, due to SOM you will have gluia. So again, ASOM, what we have taught in the previous chapters, whenever there is a concept of infection, the same narration has to go. Again, these are the etiology. While writing etiology, extra thing which is given in Dingra is they have talked about the predisposing factors. If you want, you can mention. And again, pathogenesis, if it's only as for 10 marker, you write. If it's for 5 marker, please don't mention this pathogenesis also. But if they have asked you specifically, then you have to mention. Again, as I told, first thing, what is the tubal occlusion? Then again, if there is negative pressure, what happens? Again, these are the symptoms and signs which you need to mention. So I'm just marking it since it's not an important 10 marker also. So these are the things. Again, investigation protocol for all infection, what I have told, make sure you mention the same thing. And obviously, if you are planning for surgery, you need to do the preliminary surgical investigations also. Then again, what are the treatment aims which you do have in ASOM? Again, they will have intense pain and inflammation. Obviously, you need to address that. And also, these are the symptomatic relief which you need to follow. And you need to treat the underlying infections by giving amoxicillin, because most common is beta hemolytic or all your gram positive. Of if not this, again all your gram positive or something which is important, which is the major cause. So since gram positive are present, so this is sensible to your penicillin ka group, right? So this is what you have to mention. And if this is not achieved, obviously you have to go for surgical surgery, that is nothing but myringotomy. Okay, so this is how ASOM goes. This is what is given in Dingra. First you start with antibiotic therapy, then you check for response. If it has a good response, again there is nothing. This is what is most common. But if it's increasing, then you have to again continue the antibiotic based on culture and sensitivity. Again, if it's, you have to check whether you have resolution or there is no resolution. So if there is a resolution, then it's fine. But again, if there is persistent thing, then again you have to diagnose it as OM with effusion, and you have to treat accordingly. Then again, surgical procedures I have included here itself for the fact, because whenever you are studying, at the end again I have made a separate pictures from Dingra itself. But this is what, again, indication procedure they might not ask you, but this is an MCQ itself. So where did they do? It's an anterior inferior quadrant. Again, these are the complication. By writing complication, please follow the same order: early, late. Okay, then again you have to mention about the complication due to government also. Again, glue ear is a disease of eustachian tube affecting middle ear. So if you have this concept in mind, then everything flows easily. But if you study it as a disease of ear, then you don't know what to do. Again, what are the treatment aims? Again, if there is recurrence, what you have to do? Obviously, you have to aerate the middle ear. correct, because it's already affected due to eustachian tube. Again, to prevent recurrence, this is the main thing, but to remove the underlying pathology, so this is nothing but anatomy. So if you know the anatomy, then you need to know that you need to treat it. Then obviously symptomatic relief, and again, how do you go about myringotomy? It's the same thing. Okay, that's it. So again, ASOM as an easy narration, so I have not explained you the major important things, but make sure you know the concept in broad so that you can deal with all the diseases which you need to deal. Okay, then cholesteatoma and CSOM, it's an important 10 marker itself. That too, unsafe part of CSOM is almost sure 10 marker, so make sure you study it accordingly. Again, what again you should know what are the types of CSOM. You have either safe, you have either, it's basically two types. You can either have safe and unsafe. Safe, if you have time you can study, it's a possible 5 marker, but unsafe type is an important 10 marker question itself. So how do you classify? Again, it can be, the broader classification is either primary or secondary. Again, based on when you get it, it can be further, it's majorly broadly classified before that into congenital and acquired. So again, acquired things, whenever, again, here in primary you don't have pre-existing CSOM, but in secondary, again, it's due to migration of secondary epithelium or metaplasia. So what is the concept here is that in middle ear, so if you think this as middle ear, what is the lining epithelium? Either you might have cuboidal or ciliated epithelium. But once you have squamous epithelium due to any cause, then that is called as cholesteatoma. So they say primarily these are the things which they say. Again, you might have metaplasia or basal cell hyperplasia, or due to negative pressure you might have the squamous cells which is being deposited there. But these are the secondary causes. So know the pathology. This is the pathology which you should know. So based on that, this might lead into different types of CSOM, and one kind of that is aticoantral disease part of CSOM. So what is that? It says that it involves the posterior superior part. So this is the pathogenesis. Again, clinical feature, especially while talking in ENT, while writing clinical features in ENT, make sure you write otological firstly. Before that, you need to also mention about general feature, then otological feature. In otological, again, you can mention about external ear, how it appears, and middle ear, and also inner ear, and also vestibular part. So this is how the narration has to go when you are discussing about clinical features of ENT, especially ear part. Okay, and also this is always related with your nose, that is any eustachian tube dysfunction. So you should also mention about that. And if there are any again, your speech comes, that is hyponasal voice, all those things. So this is all in broad. And also, what is the function of it? Again, while writing otological, definitely have to mention about hearing loss. And these are the complications which is guided by your anatomy itself. So these are the signs. And again, investigation, the same pattern for all your infection. But again, management of CSOM solely depends on whether you have cholesteatoma or not, whether there is no cholesteatoma. So if there is cholesteatoma, then obviously either you have to go with canal wall up or canal wall down surgery with tympanoplasty. But if it's not, then you need to see what is the type of perforation. Obviously, if it's a wet, then you have to do the oral toilet and you have to cover it with antibiotic. But if it's a dry, then you have to go with myringotomy. And these are the aims. Again, well, if it's a 10 marker or 5 marker, you have to start with writing the aims. So what are your aim? For example, what do you want to do or achieve? Again, the continuation of it, complications of otitis media. Again, this is the major part. It's a probable 10 marker or 5 marker itself. Part of 10 marker is for short. So again, while writing complications of otitis media, obviously you should know this is intratemporal or something to do with ear. If then this is intracranial. So for this, how that you have to always draw the diagram. For example, if you think this as one of your diagram, so you know that here you have a communicating cavity. So think this as a middle ear. This is communicating with your mastoid with aretus and antrum. So again, what you have here, you have the petrous bone. Again, here in the fallopian canal of the middle ear, you have the facial nerve. So whenever you see, whenever you have uh, petrositis. What is the important clinic? Again, these are the complication which, if you remember the anatomy, yeah, I'm sure you will know it. So while writing about the complications of otitis media as such, make sure you know the anatomy. So first you draw the diagram, then you place the disease in order. Obviously, after mastoiditis, you will have petrositis, and again, if it's going upward of the middle ear, obviously you'll have facial nerve palsy or labyrinthitis. So this is how it has to go. Again, intracranial, again remember the anatomy part of it itself. First what happens is, either you will have extradural abscess, then you might have subdural abscess and meningitis, then it might lead to temporal lobe abscess, correct? Then again, if this communicates posteriorly, then it might lead to lateral sinus thrombophlebitis, and if this is not been corrected, then it might lead to otitis. So always know how does the anatomy goes. So ENT, especially ear and nose or even throat, is more of applied anatomy than in MBBS. It's more of applied anatomy than knowledge itself. Okay, so make sure you know it accordingly and then place the disease and come back. So based on this, they might ask you to first elaborate on the complications of CSOM, then ask you to explain any one part of their choice. So basically what they have asked till now is lateral sinus thrombophlebitis or mastoiditis. So what happens in mastoiditis? This is what, as I have explained, same thing. Again, this, since it's an infection, follow the same infection protocol. Again, pathogenesis, if they have asked for 5 marker, make sure you write it. Again, it's the same thing. Clinical feature, obviously while writing etiological you can follow the same thing, but here since local symptom is main, you have to mention about the local symptoms also. Then these are the signs. So while writing signs, obviously you have to talk about, first is external, that is inspection part of it. Then you have to mention about the mastoid thing and also tympanic membrane, and second you have to talk about hearing loss. Okay, while talking about hearing loss, you have to mention which type of it. Obviously, since it's not involving any sensory part or neural part, obviously it's a conductive hearing loss. Again, these are the important things which you need to mention, and these are the differential. If they have asked for 10 marker, you can write, otherwise you can leave. And these are the treatment aims. So obviously whenever she is in the mastoiditis, you need to hospitalize and start on you have to give cover with both gram positive aerobic and anaerobic. Okay, so based on that you can start. Then again, these are the mainstay which you consider. At the end you can go with cortical mastoidectomy and drain out all the pus which is there. Okay, what is Bezold's abscess? Again, when this pass through the medial side, when it is involving your parapharyngeal space, then that is when this mastoiditis continues, that becomes the Bezold abscess when it involves your upper part of neck. Again, same thing, same again. This is an elective procedure, but obviously you have to do this. Again, what happens in lateral sinus thrombophlebitis? Again, as I told, it communicates posteriorly. Then again you have the sigmoid sinus which is there, and there you might have thrombophlebitis, correct? So there you might have thrombus. Again, this can communicate to IJV, and you can also have thrombosis there. So always steady with anatomy, steady with the diagram, so that you know. Again, while writing all these things, to go to the second page and write the diagram, so that you can give the description of your first in first page you can give the description, or also even in second page if you write, it should be enough. So this is the general things, and these are the local things, and these are the examination ka findings. Again, investigation, obviously since it's an important thing, it's communicating posteriorly, the major thing is you have to rule meningitis. So this is the main aim of your investigation. And again, these are the complication. Again, treatment, one thing which you have to mention is you have to also talk about thrombolysis. Then what is Gradingos syndrome? If this is present, then what does it indicate? It indicates petrositis. So whenever a patient complains you of if a CSOM patient complains you of continuous ear discharge with diplopia and retroorbital pain, then you should think of that is petrositis. That is called as Gradingos syndrome. Okay, so what you will do, again you have to start them on IV antibiotic, and electively you have to take them for cortical radical mastoidectomy. Okay, so this is the major part of 5 marker, that is middle ear cutting. then middle ear infection, then these are the miscellaneous part in middle ear. So this, even if you read, you will understand what to study. Okay, so I am not explaining much part of it here. What is the important question is glomus tumor. I am just underlining or showing you which are the important things. So based on where tumor arises, these are the two important condition. Either you might have glomus jugular or glomus tympanicum. Again, these are the clinical features. So based on where is the tumor, again as I told, while writing the clinical features in ENT, mention all the otological symptoms, vestibular symptoms. Since it's a tumor, you can have the you have the neurovascular bundle in head and neck. Obviously, I have to talk about neurological symptom, basically about the cranial nerves. So while talking about cranial nerves, mention what first, visualize what are in the anatomy, what are the important things are there. Then you need to then place the disease accordingly. And these are the signs. Okay, that is rising sun sign, which you have to always mention when you are talking about glomus tumor. Okay, only they have talked about clinical features, so I have only mentioned about clinical features alone. Okay, then coming to middle ear. Okay, otosclerosis, for example, they might ask you a 5 marker as a CBQ or 3 marker as Karach knots or management part of it. So make sure this is an important part, so make sure you study accordingly. Again, what they might ask you as a part of 10 marker, they might ask you the causes of CHL. So again, you have to know CHL means only till middle ear. So until and unless till middle ear, what are the things? Again, you might have external ear, tympanic membrane, middle ear, and also nasopharynx. This will affect your middle ear and tympanic membrane. So this is an indirect relation, but all these three are direct relation. So study it accordingly so that you know how to place it and how to come back. So etiology, obviously it's an unknown thing. So though they say it's something related to hormone and pregnancy, so this is something unknown. These are the identifiable etiological factors which they have identified. Okay, pathology, again it's fine, but while writing a clinical feature, again since it's an ear topic, you have to broadly divide into otological symptoms and vestibular symptoms, and always you have to mention about this. This is an independent 3 marker itself, that is paracelsus Wilsi. So make sure you mention about this as in a separate thing also. Then this is Schwarz sign. This is also an important thing which you have to mention. Then again, investigation, this is a firstly, while before you need to classify how to whether to diagnose, and you have to check for complications, and also this is what you will see. But major thing you have to mention is about the Karach knots, which is an important 3 marker by itself. So again, while writing on examination, again you have to write external ear appearance, that is inspection. Then you have to talk about hearing, then tympanic membrane, then all your special tests under hearing, that you can first mention about this, next about this, then about ear. Then ear you have to talk about Rinne's test, Weber's test. Okay, all about all these things. Since you know it's a conductive hearing loss, then you can present your examination findings also accordingly, since you know in a broader aspect. Okay, again differential, if it's for a 10 marker you can write, otherwise it's fine. Again, treatment aims, if it's an active disease, obviously you need to control, so you will give it sodium fluoride. You start the patient on sodium fluoride. But if it's already done, that means the disease is already progressed, then you have to do either stapedectomy or stepidotomy. Then also you need to give the hearing back, so also we will give the prosthesis. Then also to provide hearing, since there is a loss of hearing, and also she hears better in a noisy place, right? So you have to correct that with hearing aid and prosthesis. Again, these are the selection criteria for your hearing aid. Again, these are the contraindications where you can go with surgery or non-surgery. This is itself a 3 marker. Okay, these are the things which you need to study under middle ear. Now coming to facial nerve, this independently can come as 5 marker or 3 marker, but there are only few questions which are there. Okay, for example, they might ask you about topodiagnostic test for facial nerve, or Ramsay syndrome, or otological. All these questions, one question regarding facial nerve for 5 mark or 3 mark is short. So study all these things accordingly. And also I would recommend you to know the full facial nerve course, so that you will understand the topodiagnostic text which we do in facial nerve. Okay, this is the causes of facial nerve paralysis. Either you might have a central cause and peripheral cause. Again, in periphery, you should know where and all it passes. First, it is in the cranium, so you might have intracranial cause. then it comes to the middle ear, that is intratemporal cause. Then it leaves the ear and it goes and lies in the parotid and also supplies ganglions, right? Parasympathetic ganglions. So you have to talk about the extratemporal part also. The major thing which we as an ENT specialist worry is about the intertemporal part. Again, what are the causes of facial nerve paralysis in intratemporal part? One major important cause is idiopathic, that is Bell's palsy. Then Ramsay syndrome, that is HSV. Then also due to trauma or any neoplasm. So when you know where does it go, so I would recommend you to watch Najib's video, which is there in YouTube for free. He has explained it really well. I think it's just for 30 minutes or 1 hour. So make sure you study that part properly. So that's one important thing which I would like to say. Then again, Bell's palsy, this independently can come as 5 marker or 3 marker. So again, they might ask you about the etiology part of it. So this is one of the mnemonic which you can, if you want, you can remember. So again, these are the major things. And also while writing about the clinical feature, please refer the CNS part of medicine, which is already there. So first, while writing any neurological symptoms, again you have to talk it in terms of sensory, motor, then autonomic, then any reflexes. So based on this, present the clinical feature accordingly. You can refer the medicine notes which is there, and also it's recommended to draw a diagram so that you are presenting in a well lit form. Again, management treatment aims you have to write. Again, what is the important thing? The facial nerve paralysis, because fallopian tube which is present has facial nerve which is bound to get inflamed. So to reduce that, what is the major thing which we start on? Steroid. So again, what are the complication of this? Again, exposure keratitis, all those things. So to prevent it, you have to start, you have to protect the eye. So again, you have to prevent exposure keratitis. Again, if facial nerve paralysis is already set, then you have to do surgical decompression or physiotherapy. Again, regarding Ramsay syndrome, then one important thing you should know, it's due to infection of HSV. So if you know about the treatment protocol is same things. Again, clinical feature is same except for the fact that you will have one infectious thing. That is, you might have all your viral thing. Okay. Then topo diagnostic test. So first I will explain you what does topo diagnostic test mean. So here you are trying to identify where is the lesion in facial nerve. So that is the aim. Okay. So based on this, so you should know what are the its facial nerve is both motor and it has, again, secretomotor is because of the parasympathetic ganglion which is there. Majorly it's it also has the motor part and sensory part. So what is it? It's a mixed nerve. Correct. So you have to check. So again, to test for lacrimation, obviously you go with Schirmer's test. Again, to check for your all autonomy, that is secretomotor part. Again, these three obviously comes under secretomotor, that is salivation and taste and lacrimation. So if lacrimation is reduced, then the lesion is in geniculate ganglion. But if salivation is reduced, then again salivation or taste for that matter, it's above chorda tympani. Okay. But if stapedius is non-functional, then this is where the problem is. So here I know I have not explained you because the facial nerve course itself is complex. So I would recommend you to watch that video and then come and study the notes. And coming to here, the major things is Meniere's disease. Again, it's an important 5 marker. Again, you might get a CBQ based on it. So study it upon it. And these are the etiology. These are the clinical feature. Again, while I told, while talking about clinical feature, you have to mention about majorly these two things. Okay. Again, you have to mention about the vertigo with the vagal symptoms. That is what important thing. And also examination findings, all the important things again related to your hearing loss, you have to talk. Okay. And this is one of the diagnostic thing. Okay. SP by AP more than 30% is diagnostic, so you need to talk, and this is almost absolute. So we don't do this. What we do after this, obviously vertigo symptoms reduces, but make sure you present all this. Okay. And again, if you want to make a diagnosis according to American Academy of ENT, these are the things which they have presented. This is what was given in that. Certainly you can make a diagnosis if you have a histopathological report, but again, these are the definitive and probable things when you can say it's a Meniere's. Okay. And what are the treatment aims? The first thing is you have to control active vertigo, then also you have to advise low salt diet, and avoid caffeine. Okay, then these are the way you manage your chronic phase. And also you have to talk about hearing. So if it's already a dead ear, that means if you are unable to hear, obviously you go with what? You go with labyrinthectomy. But if the patient has hearing, then obviously you can try with all the other things. Again, vasodilator, carbogen, or beta histine. Then major important topic is, again you have to talk about the intratympanic gentamicin therapy via grommet insertion. Okay, then these are the other operation which you want to do if your hearing is proper. Okay, if hearing is not there, then obviously you go with the labyrinthectomy. So make sure you revise it accordingly, since it's an important question. Okay, then acoustic neuroma, again you might get a 3 marker. So again, while talking about any of the new brain tumors, again you need to talk about every symptoms. Okay, so I don't think I need to explain, because it itself is self-explanatory. Then McEwen's triangle, one diagram related to anatomy is sure, so make sure to present. Okay, then one question related to your basic science, for example anatomy, physiology, is important, so make sure you study that part also. Then again, I have not drawn all the McEwen's triangle. I have drawn the diagram. This is there in next chapter, but these two make sure you go and study. Okay, again what are the intratympanic muscles? Tensor tympani and stapedius. Again, I am sure you can mention the function also, because I already mentioned it. These are the nerve supply. Again, while talking about the nerve supply, I have to talk about pinna, external auditory canal, and tympanic membrane. Make sure you study it, because it's a short 3 marker. Either one of the above has to come, or something related to physiology, for example theories of hearing or organ of corti. So again, while writing the nerve pathway, I'm sure you know this mnemonic of E. coli MA. So make sure you know it and present it accordingly. I'm not explaining this part quantitatively, because this is something to do with basic science. Again, these are the theories. Again, since it's a 3 marker question, no 3 theories. Even if it's there are extra theory, don't study, because it's not important and it's just for a 3 marker. Again, what is organ of corti? This is the major important thing. And what are the components itself? They can ask you for 3 marker. Again, impedance matching, something to do with physiology, not important. Assessment of hearing. Okay, this is a 5 marker, or something to do with hearing aids. Okay, so make sure you know what you are studying. So these are the important questions, though this is not the most important thing. Again, tympanometry, again know the concept. What is that? Here you have negative pressure. Here there is no pressure change, but here you will have positive pressure. So based on this, again you might have normal thing. Again you might have if it's fixed, then you will have AS, which is there in OS. Okay, then again if it's a thin and lax tympanic membrane, you will have AD. These are the tuning fork tests which we all do. I am sure you would have studied. Again, while doing Rinnes and Fevers, I hope you know, first you do Weber's, then you check for lateralization, then you go with Rinnes. Okay, this is what we do in OPD. Though first we all study Rinnes, but this is in an OPD. First you need to do Weber's, then you have to check if there is lateralization or no lateralization. Then you need to do Rinnes, and you have to check whether it's normal or negative. It's normal, think of either in normal or SNHL based on your Weber's thing. Okay, so I'm not explaining, because I am sure you know it. Again, coming to diseases of external ear, this is the most important thing. This and things. This they might ask. Again, malignant. Is it malignant? No, it's an inflammatory condition caused due to Pseudomonas. Okay, so since it's an infection, it follows the same narration. Again, it's the same thing. The major thing is rule out DM. If it's present, again you have to control DM. So this is what the antibiotic you give. Since it's an anaerobic thing, Pseudomonas is one of the highly resistant organisms. So you have to know what are the antibiotics you give. Again, mycosis is something to do with fungal infection. So again, while writing that, again you have to do otological symptoms and mass features. Again, make sure you mention all these things. Again, management of foreign body independently can come as remarker. You have to first write whether it's a living or non-living. Again, if it's a living, you have to kill it, then take it out. Okay. Okay, make sure you mention it. Okay, then again management depends on type, duration and living condition of the foreign body. So again you can go with either forceps removal based on the condition of or type of foreign body. These are the options which you have. Again, as I told, if it's a living, how do you kill it, either by oil or chloroform, then you remove it. Again, keratosis obturans, again when this is present in your external ear. Okay, that is called as keratosis obturans. Again, it's the same thing. Here you have to talk about mass symptoms according to a surgeon. This is what you do. Traumatic perforation, again not asked, but I have just mentioned it. If you have time, you can definitely go and study about it. In tympanosclerosis, estrogen tube function 3 marker. This is an RS2 type of question, so I'm not discussing much, but study it. Again, this is not asked. If you are interested, you can study. Can come as 3 marker. Is never asked in. Again, this is where the proper 5 marker ka lost question comes. That is hearing aid, deaf child, deaf mutism, all those things. Again, while writing the causes of hearing deaf child, again you have to talk about prenatal factors, perinatal factors and postnatal. Okay, and again prenatal factors either can be due to infantile factors or maternal factors. Again, these are the perinatal cause and these are the postnatal cause. Again, evaluation, how do you do an evaluation? Based on the timeline I have just presented it, make sure you study it accordingly. Okay, again, if it's from 6 months to 12 months, you do some distracted techniques to check whether other part is proper. So based on that, you go with objective tests and assess the aim and assess the etiologies also. And again, you have to rule out any other pathologies in neonatal. Okay, because again, I hope you know, hearing loss again can be broadly divided into prelingual or postlingual. If it's prelingual, then it's a duty to give hearing in a specific amount of time so that the baby learns the language also. So these are the aims. So based on that, these are the rehabilitation things which you have. Again, rehabilitation, as I told, that or this is a sure 5 marker. So these are the hearing aids. So we have to talk about conventional hearing aids and BERA and also implantable hearing aids. So these are the indications. So when will you give an hearing aid? Again, should be a deaf child or whether if surgery has failed and it has severe to profound SNHL. Okay. So this is the patient profile, complication. But what important thing they ask is about cochlear implants. Okay. Again, the components itself is not important, but candidate profile for 3 marker is an important thing. So make sure you study according. Again, bilateral SNHL with what type of SNHL? That is profound. Okay. Again, 3 marker narration. Again, 3 things you remember: causes. Okay, so these are the causes of referred otolgia. So make sure, if you are feeling it difficult to remember all these things, again remember any 3 things. Again, 10 or again spinal nerves or 5th cranial nerve. Again, tinnitus again divided into subjective and objective. Remember 3 year, remember 2 year. Okay, that should be more than enough. Again, types of hearing loss, obviously I think you know, or there are only 2 things. Again, conductive hearing loss or sensory hearing loss, or both, that is mixed. So based on that, you also have tympanoplasty, and these ototoxic drugs can come as 5 marker or 3 marker. Okay. Again, this is tympanoplastica classification, and while writing ototoxic drugs, since they have asked you to mention the classification, so you should know 5 classes, since it's a potential 5 marker or a 3 marker. So you study it accordingly. Remember all the chapters in pharmacology, everyone has a ototoxic thing. Okay. And presbycusis, again SNHL due to old age. So again, it might have all these causes. Okay, the major things which you need to talk about is hearing aids. Again, these are the causes of sudden SNHL. Again, major thing what people forget about is this. Major is this: if you start the patient on steroids, then you can give back the hearing as normal. Then acoustic trauma, I don't think this is an important thing. If you have time, you can study. NIHL, again based on the threshold. Again, this is not asked. This is a PSI I'm talking about. And caloric test, RS2 type of question. If they want you to ask one question, they might ask. Again, study. There's nothing for me to explain. Again, these are the vestibular function tests. that is fistula test and all those things. This as an, if even you study, this should be enough. And these are the things that is vestibular neuritis and all those things. So make sure you study it accordingly. And as I told, the major important thing which you need to have which you need to study is all these things. Okay, though anatomy physiology has the proper narration part of it, but important thing is what people do is they study all disease, but they forget about your basic paraclinical science, paraclinical and preclinical knowledge. And also important thing which they forget is all the diagrams. You have to revise all the diagrams of anatomy a day before exam, because without that you cannot do anything. Okay, this is something to do with vestibular neuritis and BPPV. I'm sure you would have seen, if you have gone into once, at least if you have gone into ENT OPD, then at least 1 or 2 cases in a day you will see about BPPV. I don't think I need to explain anything here, but investigation and one more diagnostic test, I think you should know what you are going to do. Okay, please manual to correct it, and also Dix Albright's manual to know the type, whether it's BPPV or not a BPPV is something which you need to know. That's about ear. So major things, first you have to study about the infection part of it, then you need to study about the non-infectious part of middle ear. Middle ear is more important than inner ear, then least important is external ear. External ear you might get question or you might not get question, but major thing which people miss is anatomy and diagrams, and also the physiology, is also the nerve test and all the calorie and investigation ka part of it. So make sure you study that and be a differentiator for the rest of your batch. And coming to part 2, that is nose part of it. First thing which we all need to discuss is about epistaxis. So again, I have made the notes. I will just give you the concept here. So while writing causes, again divide into local cause, non-local cause. Okay, again in local cause, again you might have traumatic and non-traumatic. So based on this, you classify accordingly and place the disease and place the causes. Even if you know one thing under each system, for example this, it should be more than enough. Okay, again while writing local cause, what are the local things which are present? Either you might have nose and also the nasopharynx, so both things has to be present. Okay, then again it's better if you draw a lateral wall of nose septum ka diagram also. Again mention about anterior ethmoidal artery, posterior ethmoidal artery, then also sphenopalatine artery, labial artery, and also mention about Kisselbach spaces, because you can present it and get marks, right? So make sure you present it accordingly. Again, these are the things, I'm sure you know it. Again aims, again this is the major thing, and this. Then again, how do you control it? First, you obviously go with Trotter's method. But if it's not able to control, again, what is the next thing you do? Cautery. Again, you can do chemical cautery with AgNO3 or electrocautery, that is you use bipolar, since it has 2 things, so that other neurovascular structures which are present should be unarmed. Then if it's not being controlled even by this, then what you go with? Obviously, you go with ligation of arteries which are present. After this you go with packing. I'm so sorry. Again you might have anterior nose packing or posterior nose packing. Then again, if this is not working, then what we do is ligation. Okay, so this is the broader concept. So based on this, here I have explained all the important steps which is there in the book itself. So make sure you study this accordingly to the specific thing. For example, if you are doing a FES and if you have orbital edema, then obviously you don't follow this protocol. Obviously you know that it's from the anterior ethmoidal artery, so you know what to do. Again this is for the condition where you cannot find or where you cannot know where is the cause. Again, if you are obviously if you know where the artery is bleeding, obviously by chemical cautery or by your electrocautery you would have ligated it already, but this protocol is followed when you are unable to know where is the ligation. Okay, again all these things I don't think I need to discuss, because it's an in and out important topic. I am sure you know it. Again, trauma to face, is it the 5 marker or 3 marker? Important question. Okay, this is the major thing which does this as a CBQ itself is an important thing, so make sure you study it accordingly. Fistula has not been asked, but I have mentioned so that you know. Again, what they will ask about nasal bone fracture is that they will ask deformities of nose for 3 marker. Again, you have to write about crook nose, then DNS and saddle nose. Okay, C shaped or S shaped, all those things you need to ask, and that should be enough. Then again, regarding sinusitis, again the major thing is sinusitis and polyps. The major thing is polyps can be an independent 10 marker or 5 marker. Mostly they have asked you about ethmoidal polyp. That is the important thing. Again, I am sure ethmoidal or what is the ethmoidal air cells or more. So whenever you see multiple polyps, it's most likely ethmoidal. But if you are having one that is restricted, which is present in the maxillary antrum, then it's mostly antrocoinal polyp or so know how to differentiate it so that you don't go wrong in the 10 marker. Then it follows the same easy narration which has. Okay. Again, you should know about Bernoulli's principle. Okay, based on that, you can definitely mention all the things. Okay, while writing clinical feature, first thing what you have to think is about since it's a mass, again pressure symptoms or obstructive symptoms is something which you all need to measure and you need mention and you have to come back. Okay, these are the investigations which you need to follow. Again, this I have just given you the concept. You can just see that maxillary or antrocoinal. Antrocoinal is something to do with coina. So where is coina in the maxillary? Antrum. Correct. Antrum is that thing, but maxillary thing, right? So based on that, I have just given you the concept behind it. You can just refer. And these are the major important things which you need to know. Again, difference between this is an independent 5 marker. Okay. Again, sinusitis. Medicine, it's an important 5 marker. Here I have just given you the things. So again, this can be asked for 3 marker. This was an RS2 type of question, but I don't know, they might ask you for 3 markers, so make sure you study it. Okay, so these are the clinical features of sinusitis. Again, chronic sinusitis, the major thing what you do is FES. Okay, that if you remember, that should be enough. And also remember the treatment aims. Obviously you have to remove it, and also you have to restore the sinus ventilation, because you will have the headache and heaviness. FES, sure 5 marker or 3 marker under investigation part of it. So you should know this very in and out you have to know. Again, while writing FESCA in indication, no, you can write it as nasal indication and extra nasal indications broadly. So under extra nasal indication, you can write about all these things, but under nasal, I want you to write these 3 important things, which is in and out important. Okay, again, while writing a complication, again obviously you can write it like this, or major thing which I would like to highlight is this one, then this one, then also this thing. Okay, these are the major important things as a complication issue. Okay, again, complication of sinusitis, I am sure you would have studied in medicine, and it's also discussed, so make sure you study it. Again, divide it into local, then what is there near the sinus, again you have the eye, again you have the head, then also you might infection might ascend up or descend out. So based on that, you can have a complication. Again, this is a proper 3 marker. Okay, these things I am not explaining, wanted. Rhinophyma, and also difference between rhinoplasty, SMR, and your DNS Kadar operation is an independent 3 marker. So what is happening in rhinophyma is it's hypertrophy of sebaceous gland at tip of nose. So these are the clinical features which you have, and this is the treatment protocol which you need to follow. Okay. And nasal septum and its disorders, major thing is about perforation and abscess. So what you do in both cases, in abscess obviously you do incision and drainage and give antibiotic prophylaxis, but in septal perforation what you do is you have crusting and all those things, so you have to you have to prevent it. So that is one of the important things. And also DNS in and out, I think you would have seen. Okay, these are the things which I told can become as independent 3 markers. So these are the clinical features. Okay, again, to check for patency of your nasal valve, you do something called as Cottage test. So I am sure you have seen the diagram. Again, here it's an emergency, so you need to incise and drain the hematoma which is present with the secondary antibiotic prophylaxis. Here it's already an abscess, so obviously what you need to do, you need to incise and drainage, and you have to give them you have to start them on prophylaxis. Again, these are the causes of septal perforation, and this is how you treat it. Again, atrophic rhinitis, possibly a 3 marker or a 5 marker. Major thing, again, please don't study this. Clinical feature is something which you need to know. And also aim of investigation, obviously you do nasal saline douching. Okay, that is one important thing which you need to do. And obviously if nothing works, obviously go for Ring's operation. Miscellaneous, these miscellaneous itself is important here. A CBQ of for 5 marker might come here. Okay, so make sure you study that. I don't think coinal, I will just mark tracheostomy is not done. Okay, the major thing which you need to mention it was McGowan's technique. Okay, so I'm sure you know about it, so I'm not talking. But while writing CSF rhinorrhea traumatic, 95% of the causes is traumatic, and these are the non-traumatic cause. Again, while writing causes, as I told, I'll go with the same narration of your Robbins pathology. Okay, these are the complaints of, and this is one thing which you have to mention: all the reservoir sign, double target sign. Make sure you write it, and also people forget they write beta to other things because you have microglobulin, all those things. But remember transferrin. Okay, remember CT, the CSF rhinorrhea transferrin. Okay, one important thing. Again, to localize the lesion, you have to do CT or MRI. Again, it's an elective procedure where you repair it later, but you have to give an antibiotic prophylaxis to prevent meningitis and to prevent the further CSF leaking. Obviously, you need to avoid the intracranial pressure. So these are the things which you do. Again, what is lit and what is rhino? Rhino is nose. Stone in the nose is rhinolit. Again, you have to remove it. Okay. Again, this has the same narration, so I'm not talking about it. Allergic, again, important. These are the major things. Obviously, you will mention about this, and if nothing is working, you have to talk about this. Again, this non-allergic, it's an important 3 marker. I'm sure you know it. So study it accordingly. Again, inverted papilloma. JNA is more important than inverted papilloma. If you study inverted papilloma, that should be more than enough. What is the major thing? It's a tumor of non-olfactory mucosa. Again, this was asked as 3 marker, so I've just mentioned it. Again, a JNA in and out is important. This can come as 5 marker ka CBQ. Okay, so make sure you know it. Again, these are the clinical features. Since it's there in the nose, again you may have otologic and nasal and also nasopharynx. Again, this is what 2 weaker stage. So you have to also talk about ophthalmic. Okay, again differential if you want you can write, but it is not important. But again, this is the same thing. You never attempt for a biopsy. Okay, that is one thing which you should know. Again, how do you do it? It's a contrast enhanced CT. It's the investigation of choice. Okay, this thing. Staging. Okay, staging. Obviously, you know there are 3 stages. Okay, first stage and last stage are easy to remember. So, what is A and B in this thing? Again, cranial. That is intracranial spread, which is minimal, but intracranial spread, which is maximum. Again, this is what is stage 2 to lateral spread. Okay, to all the foraminas, you know. Again, I'm not sure. I think it's pinopalatine foramen, then pterygoid fossa, something like that. But how I remember is second thing is something to do with foramen. But again, at the end, full of it with orbit, something like that is there. So make sure you study it because it's an important thing. I don't know how I missed it. And also here, limited to your nose and nasopharynx. Okay, so based on this we'll operate. Again, if it's 3B, obviously what to do, palliative RT. Otherwise you can surgically remove, though it might bleed, but you will embolize it and reduce the blood flow, then you need to do accordingly. Again, that's it about nose. Nose has a very easy narration. There are only 2 and 3 topics which you need to study properly. For example, epistaxis and polyps, and also the sinusitis part of it, and a JNA part of it for a CBQ. And FES for an 5 marker can come provided there are no any other investigation part diagnosis there. So make that independently can come as a 5 marker. So make sure you study that also. So first after year, make sure you study nose because you can finish it off easily. Then important thing what people forget in throat is they forget about the broader sections which they are given. If you start studying only about larynx, or for example if you want to study about CA larynx, which is just an RS2 question and just as once or twice, you are wasting your time. So make sure you divide it, then finish all these things, then go back to CA larynx or anything which you are more interested in studying and study accordingly. But before only if you waste time on that, then you are doing a mistake. So again, these are the RS questions which are there. 42 has no RS question, and these thing again, this throat will become a surgical overlap topic which I have discussed extensively in surgery paper 1. So you can refer that part. Here I have provided you with the notes again which are important to ENT and which is an important RS questions I have discussed. Again, Vincent's angina. Why is it Vincent's angina? First you need to know the causative organism and what do you do. Since it's an cellulitis, so make sure you write it. Why do you do an incision and drainage here? To relieve the tension. Okay, that is important thing which you need to mention. Submucosal fibrosis, I'm sure in head and neck part of your surgery I have discussed. So these are the important things. Okay, pathogenesis not required. Okay, clinical features, I'm sure if you study once you will be able to write about. Again, all these things I've discussed in surgery. Make sure you refer to the surgery part 1 of it. Okay, again these things I've discussed in surgery. Same Ward's ring. Okay, this possible 5 marker or 3 marker for diagram. So what is the concept of Ward's ring? Every opening has one. For example, adenoid. Okay, here you have tonsils. Again here you have tubal tonsils. Okay, so every opening, nasopharynx, oropharynx and laryngopharynx, everything has one lymphoid tissue, so that it prevents the infection and provide local immunity over there. Again, Killian's disease. What is Killian's disease has to do? Again, due to the muscular weakness, you will have a bulging. Okay. Pyriform fossa, I'm sure you would have studied in anatomy. Again, Ward's ring diagram, I hope you should know in and out of it. And these are the components. Okay. Functions also. Right. Adenoid phases, again, blood supply is an important 3 marker. Adenoiditis, okay, if you want to study, you can write, but these are the phases. Okay. In blood supply, this is of tonsils. Okay, I have missed it. So, this is of adenoid. So, study it accordingly. In tonsillitis, what is an important question is tonsillectomy, which I will be discussing later. Okay. And DD for white patch, this is all surgery topic. I'm skipping all these things. Quinsy. Okay. So, what is it? It's a peritonsillar abscess. Major differential is parapharyngeal space infection. That is neck space infection. You need to differentiate based on this. Again, this is hot potato voice is something which they look for, and again, this is what we do. Okay, you have to address all these things. Retropharyngeal abscess, again infectious protocol, the same thing, but if there is an airway compromise, again you have to do a tracheostomy. In prevertebral abscess, which is the most common cause, that is TB, that is pot spine. So mention that. Again, tumors of oropharynx, in that Eagle syndrome is something. This is the calcification or elongation of styloid process. Again, airway, very important. I don't think I need to explain anything here. It has an easy narration, so study accordingly. The major thing, again, I think there's a repetition here. Sorry. Yeah. Sorry for the repetition of the notes. Laryngomalacia, it's of infant. The major thing is just reassurance. Again, you might give calcium supplement as a placebo. Okay. Tracheostomy, in and out of tracheostomy is important. Independent 10 marker has been asked once or twice or even more than twice, and independent 5 marker is short. If anything is not as either as 10 marker or 5 marker, a 3 marker is always asked. Okay, so know it accordingly, and while writing indications, mention it accordingly and place it and come back. Again, the major types which you all discuss, if we all know, is about elective or emergency. Again, 2 also has different technique. If it's an elective, obviously you have to go for a vertical incision, but if it's an emergency, again you have a different horizontal, all those things. But make sure you know the procedures also accordingly. How do you do, where do you cut, and what do you insert, and complication of it. Complication, the major important thing people forget is about the stenosis, okay, and TEF. This is again related to your wound part of it. But again, what major people miss about this, about all these things, in and out. There's nothing which you can leave in tracheostomy. You need to study in and out. So I've just provided you with the notes, and these are the post-operative care. You have to do constant suction. You won't wait until it goes for a stenosis. Suction is done to prevent stenosis. Okay, that is one important thing. And also, these are the major antibiotic prophylaxis. How do you do the care of tracheostomy? All these things are important. Again, this was not asked. Okay, if you want, you can start. 3 marker for RH2 types. I don't know. This is anatomy questions. I don't know why they are asking these type of questions in ENT also. Again, I'm not discussing any of it. Okay. Again, acute epiglottitis, one important thing is, obviously, you remember about the thumb sign, which you see on X-ray. And also, it's an basically you have to secure airway. Otherwise, you might collapse hemodynamically also. And also, if you want, you can give the infection. Again, here, Rimke's edema. Study talk on TB larynx. Again, major thing is this thing. Again, this for MCQ, it's a short question, but I have not seen much questions being asked. Even as a CBQ, I have not seen no supply of larynx being asked. But if you want to study, you can always study. Okay. Pre-malignant lesions, I'm sure you know it. And these are larynx, not much questions are expected. So if you even study accordingly, this is why stage 3 CL larynx is asked is because of once vocal cord becomes fixed, it falls under stage 3. Okay, so see, that's what a CA oral cavity, CA larynx. These are TNM staging itself are complex, and there are very less times an RS question being as asked. So if you have time, definitely you can go and start about it. But what is the main aim of the video? Aim of the video in a concise amount of time, you need to study all the important topics, all the important questions, or predict all the things, and you study it accordingly, and you place it and get first you get above 50 marks. That's the first aim of the video. Then if you have time, definitely you can approach me. There's also a link of Instagram it's being given. Then you can ask any required query or if any doubts or any queries if you have, definitely you can come and ask me. Okay, I am happy to help any one of you. But thing is, first aim is to pass. And this is what, again, if for to pass, if you want to study CL lines, even if you leave CL lines question, but if you have studied the whole notes, I think you will definitely pass. Okay, so the aim, first understand the aim of the video, then you know what to do. Again, is all a 3-marker question. What are the causes of Holz's? Again, go with the Robbins pathological, same thing, congenital and acquired. In congenital, these are the conditions. In acquired, again follows the same narration of Robbins, that is inflammatory cause, trauma, non-trauma. Again inflammatory and infectious, inflammatory and neoplasm. So place it accordingly. And also one important thing which people forget is about the paralysis, which you should know. Again, puberophonia, something to do with puberty. Again, if there is no change of us, then obviously you need to do. This is the procedure name. So make sure you present the procedure again. Okay. What is aperta? That is excessive. Then clausa is hyponasal voice. Okay. So study it accordingly. So make sure you know the clauses. Okay. I think that should be more than enough. Again, esophagus. Again, foreign body. Again, if you want to present this graph, you can present. This is drawn by my own. Okay. Not given in any textbook, but I just mentioned it because it was fitting into picture and just wanted to fit the picture. Okay, this is what you do. First thing is you have to do X-ray and check whether it's an radiopaque or radiolucent. Again, thyroid, an important question in your 10 markers of surgery, but here it's not asked. But if you want, you can study this thing. But this is the only RS2 or RS3 question which is asked. So make sure you study it. Again, constriction of esophagus, I'll come to it. Okay. Mechanism of deglutition, I don't know, it's a physiology question. If you want, you can study. These all are RS2 type of questions. I don't know why they are still asking it. Okay, disorders of esophagus, again, Plummer-Vinson syndrome. Obviously, it's a pre-malignant lesion. Obviously, you need to clear out the web when you have to treat the anemia. That's one important thing. Okay. This again, hysteresis pharyngeus, I'm sure you know it. Major thing is assurance. Okay, dysphagia divided into pre-esophageal and esophageal. While talking about the dysphagia part, obviously you have something called as structural and also functional. Okay, so functional is something to do with nerve. Structural, again you might have lumen occlusion or extraluminal. Okay, so based on this, know the concept and then place it accordingly so that everything fits into picture. Pre-esophagus, above esophagus. What do you have? Oral cavity and pharynx. Okay. Again, paralytic also. Okay, so see how everything fits into places, provided you know the overall aim. So overall pattern of any paper which it goes for infection, malignancy, or traumatic, non-traumatic, or an abscess. So if you know it, then definitely if you place it, you will get half of the marks. Then remaining extra words which they expect, for example, potato voice. If you place it, then obviously you get 1 marks. Then again remaining 1 marks nobody will get. So it's already you're already achieving 3 to 4 marks, and that should be your. That should also lead you to the distinction score also. Again, HIV association in ENT, it's a competency based topic, so I have also included that. So again, these are the conditions which you can see in a HIV patient, okay, in ear, nose and oral cavity. So one ththing is about Kaposi sarcoma. I have made sure you have studied in medicine also, surgery also, and again it's there in ENT. That shows how important it is. So make sure you study it. Okay. Then these are the differentials for your midline masses. So this is proper surgical topic. So you can study from surgery also. This is the DDs for your lateral neck swelling. Okay. Then miscellaneous. So this is the 3 markers. So that asks for definition, types and applications. So again you can remember based on the wavelength of it. This is divided into argon, KTP, and carbon dioxide also. These are the properties and these are the applications. While writing application, remember here nose, throat, larynx, pharynx, everything, and you place one disease accordingly. I'm sure if you study this, everything falls into pictures. Again, so I hope you are understanding the importance of knowing all the diagrams in ENT because it's a short question. Again, now coming to your operative surgery ka part. So myringotomy, again, as I have discussed the same thing, I'm not discussing here. Again, complication of mastectomy, obviously by writing any surgical complication, you are writing early and late. In late, again, you have early and late. Sorry, intra-op and post-op. So now you know the general classification. Now you fit it everything. Again, in intra-op, what is the major thing which we'll talk about? Hemorrhage and nerve injuries. So now you fit it everything accordingly so that you know what to write and what not to write also. Okay, and these are the other important questions. Obviously, this I've just mentioned it accordingly so that you know what are the important things. Okay, again, here also about incision you can write. Okay, freeze incision and Killian's incision. Okay, that important thing also you can just mention also. This is definition and these are the principle and indication and complication. So this as an easy narration I've explained you. Again, while writing indications for any thing, what you will write? Again, you will write diagnostic indication and therapeutic indication. So based on that, you place the disease and you place the indications and come back. Okay, contraindications also. While writing that, again you can write about absolute and relative. While writing complication, if it's a surgery, obviously you go with the same narration which I told. For example, intra-op and post-op. In intra-op, you write about hemorrhage and nerve injuries, and in post-op, you write what are the important things. For example, reactionary hemorrhage or any cartilage cutting or any infection part, you write it. But here, this is not a surgery, but it's a scopy. So it's what do you say? It's a procedure, right? So these are the so basically you can classify it as minor and major also. So for constrictions of esophagus, I'm sure you would have studied from anatomy. The major thing which people miss is C6, T4, T5, T10. Okay, that is one important. Again, indication what I told, the same thing. It's an easy narration. Tonsillectomy, again you have to remember about the Paradise criteria. Make sure you place it accordingly. This is the major indication, and these are the other indication. And also one more indication which people forget is if you want to operate on. For example, if it's an Eagle syndrome and elongated stenoid and you have to remove it, for that you have to remove the tonsil. But for that, knowing anatomy is important. So in ENT, who's the boss? Who knows anatomy in and out is the boss. Okay, that's one important thing. So if you know, if you are well versed in your head and neck anatomy, if you are well versed in your diagrams, if you know where nerve ends, if you know where every structure is there, if you know all your paraganglionic fibers, or the major thing is about the all this fossa and all other important things. If you know it, definitely you will have very smooth flow in ENT. Okay, again contraindication, absolute and relative. So see, it's the same thing. Is there anything extra? For example, one thing has extra thing, so make sure you mark it again. Okay, these are the extra thing, not this one. Okay, these are the extra thing. For example, this is an extra thing. For example, this is an extra thing. So you know what are the things you need to mention. And adenoidectomy, again, these are the indication, these are the contraindication. Tracheostomy tubes, again based on this, there are many types. Based on that, you need to remember, and these are the advantage and disadvantage. Okay, see, that's it. So ENT, if you ask me, so first thing which you need to study is about the ear thing. Okay, so what is the important thing which is people forget is they start studying everything which is not important in ear. Okay, that's where first failure happens. So if you know what to cover first in ear, for example, you need to talk about your infectious part of middle ear first, then you need to talk about the non-infectious part of it, then you need to talk about the facial, now then you need to come and talk about your diseases of inner ear, basically Meniere's disease only. Then you need to talk about the diseases of external ear. Okay, this plus or minus, even if you leave this, never leave this, because this is sure 3 marker than this. Okay, so all in and out diagrams of all anatomy is important, and theories of physiology, they might come. This was an RS2, but now as per the recent RS4 guidelines, they ask more of your anatomy, applied anatomical knowledge than the basic physiology thing, and this is somewhere you will get 5 marker also. Then while coming to nose, make sure you study this part first, then this part. Okay, this and this is, I'm sure in and out you will know, but the major thing what people miss is about the CSF rhinorrhea here. This is an independent CBQ question. Okay, then again tumors, obviously this is the third part. Again, this is the last part which you need to take, but this you need to study after this. First you study about epistaxis, then about the nasal polyps, because these are the two important end marker which will come. Okay, then you come about nasal septum and all this allergic rhinitis, then talk about JNA and nasopharynx carcinoma, though this is not an RS question, but later you can study. Again, you can come and study about your sinusitis. Then when it comes to throat, first thing which you need to finish, if you ask me, is tracheostomy. In and out of tracheostomy is important. First finish this, then go for this. Okay, then you can come for this. Lastly, you can study for this. Okay, so now you know what are, then obviously operative surgeries, even if you know a broader concept, if it's something into the, or you know the proper complex. For example, if it's a complication of a surgery, obviously place it an intra-op and post-op. In intra-op you'll write about hemorrhage and nerves, and post-op you'll write accordingly. And for contraindication, obviously write about absolute and relative, and for adverse and if it's a minor procedure, obviously you write about major complication, minor complication, and you write 1, 1, 2 things. For that we will get 1 or 2 marks out of 5 marks. So again, if you box and write the important things, you will get the 3.5 to 4 marks, which is the maximum marks which you can get in the 5 mark question. So what people start doing is they'll start studying about your CA larynx, okay, vocal cord palsy. These are MCQ questions. Okay, this you are not writing a PG exam for your ENT. The major aim is they are testing whether you have applied anatomy of ENT properly. So make sure you know the applied anatomy, and also few indication, contraindication, and the instruments, and also few important diseases. For example, CSM, meningitis, autosclerosis, epistaxis, antercoronal polyp, and ethmoidal polyp, and or your tracheostomy, because it's an emergency. Obviously, in and out you should know. Then also about your adenoids and tonsils, and also esophagus ka broad concept, and also the communication concept with your surgeon. If you know this, I am sure you will get even more than first class. So, but problem is what? A day before exam, you'll start studying all nonsense which is not required. So, the aim of this video is first to pass. So, make sure you study important things a day before exam. Then, if you have time, more than welcome to study everything which is there. Okay, but revision is the key. Make sure you study and revise properly. After revising twice, you can jump and study all nonsense things which you want to study. Who is the boss in ENT? The person who knows in and out of anatomy of head and neck, ear, nose and throat is the boss. So make sure if you want to revise anatomy first, if you are watching this video before 1 month or 2 months, study your head and neck part of ENT in and out, and then come and study ENT. Then everything will start making sense. Okay, that's it. But make sure you study, you follow this pattern and study, so that everything falls into picture. Okay, that's it. I wish you the very best. Thank you.